offering it to, thank you, whoever did that.
Mhm.
Thank you, Lauren. This is the first in a series of office hours, which um, are really resulted from the survey and the collaborations that or the convenings that we've had over the past year. Today's conversation is really just to kind of bring together information that we've gathered around how nonprofits can share healthcare benefit packages, which is a complicated, complex issue, especially in the state of Vermont. And one of the things that we found in all of our convenings and our conversations is that there's things that we're allowed to do in the state of Vermont, things we're not allowed to do. And there's a lot of things that are still uncertain, we don't really understand. And so today's intent is not necessarily to give information that is, this is the way we should be doing it, but really to share what we've learned thus far, and then to offer us an opportunity as a community to have a conversation with somebody who has figured out how to do some sharing behind the scenes with her nonprofit that she leads. So Suzie has very graciously offered an hour of her time to come and share how they are doing it, and then open up for conversation amongst all of us about what we see as what questions we might have for Suzie, what questions we might have for the community at large, and kind of figure out if there's things that we could and should be doing as a collaborative group to start to bring down those healthcare costs that we are all facing. We are starting with healthcare because that's what the community has said is the most urgent need, which I know all of you know. The next part of this series is going to talk about how do we share services behind the scenes, and that one's in December. The last of this series is in January, and it's really around how do we collaborate to deepen impact. I will put the information right now just into the chat around the next two of this series, and we will then start. So the way we've structured today, I'm going to give two PowerPoint slides that are going to give you kind of an idea of what the models are that we've learned thus far, what we've learned about what the restrictions are in the state of Vermont. There was quite a bit of rumor about what was allowed and what wasn't allowed, and we tried to figure out really what was allowed and not. And then I'll pass this on to Suzie. Does that sound good? If you guys have questions, I don't know, for me, if you have questions, you're welcome to come off mute and just jump in. For Suzie, I'll let Suzie create her own boundaries around how to ask questions. Does that sound good?
Mhm.
Awesome. Okay. So I'm going to share my screen and just give kind of two summary slides. All right. So when we began this journey of kind of looking at how nonprofits are collaborating in the state of Vermont, the thing that came up the most was a huge desire to understand how to share healthcare benefit costs. And I will say that I am absolutely not a expert at this and have just started kind of diving in, but there are a couple of big picture things that I think I wanted to just bring out in terms of the learnings that we've figured out so far. There are kind of two big ways or there's multiple ways that nonprofits can share costs. The one that I will let Suzie talk about the one that she has, but it's kind of an umbrella organization that shares the cost of a healthcare benefit manager. That is a model that is, a model that incorporates kind of organizations that have similar structures and similar ways of working under one umbrella organization that then can share a variety of different services based on membership fees that are paid. And I'll let Suzie dive into that and correct me at any point when I made that mistake. Another way that some organizations in the state are trying to reduce the cost of the actual healthcare plans is using a PEO, a professional employee organization. The pros of that is it can help reduce the overall cost for employer share of healthcare insurance. The cons are that once you have signed up to be part of a PEO, you enter the risk pool of all the other organizations that are in there, and you lose some of the autonomy of being a separate entity. And there are legal parts of that I don't quite understand, but if there's questions, I will be happy to take them because I am talking to these two organizations that I have links to later this month. The first one of these two links I have on the screen right now. The is the National PEO. It provides you a searchable by state database for finding a PEO that fits your needs. The second is the Nonprofit Connect, which is a wide variety of different shared service providers for nonprofits. And they do have a membership healthcare benefit plan. It is complicated and complex, but if people are interested, there will be more information coming out about my conversation with them. And if anybody has information about either of these two groups during the Q&A, I would encourage people to speak up and talk about their experiences. The next thing I was going to bring up, and I know that Common Good is aware of this particular model, is in the state of Connecticut, nonprofits have been joining forces and advocating to try to access the state employee health care plan as a way to reduce costs. I don't know if that's a reality for the state of Vermont, but it is an interesting way to kind of start to think about how do we as a community access cheaper plans and plans that are more robust. And so I just mention it as something that I know one of our fellow New England states is pursuing. They've not been successful yet, and there probably would be some challenges within the state of Vermont, but it's something to consider thinking about. The last models that I will bring up, the Minnesota Nonprofit Association and the Berkshire Nonprofit Center, both nonprofits themselves who provide support services to nonprofits in their geographic area, provide healthcare through an association plan, which we'll talk about next and why this doesn't work in the state of Vermont. But they provide healthcare plans through their membership. And it's something that we in the state of Vermont, as you will see in our next, cannot do. But we are monitoring. The Berkshire Nonprofit Center is just starting their association plan, and they will be piloting it on January 1st. And we are in conversation with the insurance plan provider to see if they can figure out a way to do this in the state of Vermont. There is no guarantee, but it's an interesting model for us to be exploring and thinking about. Talking about association plans, when we started talking during one of our many convenings, there was a long kind of conversation about what we can and cannot do in the state of Vermont. And there was confusion around an association plan and a PEO. And so I just wanted to kind of bring up kind of the difference between, in the state of Vermont in 2019, association plans were outlawed to become compliant with the Department of Labor. So we no longer have access to association plans like that of the Minnesota Nonprofit Association, where there is a group, there is an entity that is formed that buys healthcare at large with a large pool of potential employees and then can share it out amongst different organizations. We cannot do that in the state of Vermont, but there could be potential advocacy that we might want to think about as a community to go back to our legislators and say, is there a way around some of this? A PEO is not that. And we do have access as nonprofits to PEOs in the state of Vermont, but there are definitely cons to that model. I'm sure some of you who have explored that might be able to explain a little bit more what those cons are. But I wanted to just clarify because that was a good information that I think there was not clarity on around the last time we spoke of this. So with that, I'm going to stop sharing. There's questions, we can humor them now, or we can humor them at the end, but I was going to open it up for Suzie to talk about what her organization here in the state of Vermont actually does. So Suzie Walker is the executive director of the Vermont Recovery Partners.
Recovery Partners of Vermont.
Recovery Partners, I got it backwards. Recovery Partners of Vermont. I apologize, Suzie. Suzie, thank you so much for joining us today. I will allow you to.
Thank you. It's wonderful to be here, and I look forward to learning from you as well, because this is just a fascinating area for sure. So I thought I'd start with, come on, do what I tell you. Okay. Just a brief introduction of how we got to where we are at Recovery Partners of Vermont. We've only been a membership organization since 2021. Prior to that, we were a more traditional network that came together to work on mutual goals. But when we became a membership in 2021, it was for a couple of reasons. One being that we had more freedom to advocate for ourselves and our members' needs. Prior to that, our network was state funded as well as our members, and we were always advocating with our oversight body, which was always a very awkward and clumsy fit. So we set that aside and moved on, and having shared services is a big part of what we did. So the Vermont Recovery Network, we were all affiliated since our inception back in 2007 and started with 5 recovery centers and grew to 12 under the Vermont Recovery Network, which did a lot of things we still do, attracting funding and securing grants on behalf of the membership. And it allowed us to have uniform services across the state so that no matter where in the state somebody goes for recovery supports, they have a common experience. It's not completely different everywhere they go. So we were stronger and more effective working together. Um, and then in 2021, the network organizations themselves chose to change the governance structure to allow for more growth, diversification, and more freedom in charting our own path. The new membership organization would be funded through member dues, grants, foundation support, and fundraising. Recovery Partners itself would not rely on state funding at all. And that freedom from state funding meant that we had more freedom to advocate for our own needs in uh, different ways. The new membership would include peer recovery centers as well as recovery residence organizations, which was new at the time that we became a membership. The core members are peer-run recovery centers and residences that provide direct recovery services to their constituencies. Recovery Partners of Vermont would maintain a lean staff to support the membership by attracting funding, providing programming, and workforce development based on member needs. We would also serve as a central point of support to avoid redundancies in our system and free the members to focus on their very important direct service work. So in our membership, Recovery Partners, RPV for short, we establish a budget and attract funding to supplement the member dues so we can come up with our work plan for the year. The goal is to keep the member dues manageable while providing the benefits that members couldn't manage on their own. The membership votes on the budget and the annual dues amount. This year, member dues comprise 35% of our budget, and RPV's contributions are 65%. And for context, the member dues this year are $10,420 for the benefits you'll see shortly. We have a memo of understanding that captures these details and an invoice that goes out. Members can pay dues monthly, quarterly, biannually, or all at once. And a member benefits document summarizes the current year's benefits. Here's a summary of those. The one we're talking about here today, Recovery Partners of Vermont contracts with a health insurance management firm to manage our group coverage. Unlike an association plan that was just mentioned, we were already existing. We had shared mission, vision, and goals. So it was different for us as an umbrella organization to go to find our health management partner and set up an arrangement where RPV maintains the contract with the insurance firm and our members sign what's called a joinder agreement under the RPV agreement that allows them to participate in that group insurance coverage through our contract. And then once they sign that agreement, RPV manages the overall relationship and contract and meetings and such. But once each member has an arrangement with the firm, they handle their staff's insurance needs as works for their organization. I would say most of them have an arrangement where the organization pays 80% of coverage and the employee pays 20%. Some, though, are smaller or have larger staffs and just couldn't handle the cost of providing insurance to everyone. Or so they do it in different ways. They might have a stipend versus that 80/20 model. The firm itself watches industry trends and makes recommendations. We stay in touch. They have a mid-year review, and we just did our end-of-year review. And they had warned us mid-year that due to the cost, it would be likely that we would be switching from Blue, or they would recommend that we switch from Blue Cross to Blue Shield, and that's just what we decided to do last week. It represents a significant savings for our members. And so centralizing this benefit under RPV's umbrella, it's a cost of $25,000 a year to RPV, but that saves the members individually having to pay that $25,000, and they pay just a portion of that through their dues. Other member benefits, just for context, with the same firm, we have a separate contract to provide HR support for our members. Some of them are small enough or their staffing model just doesn't include having HR on site. And, it's complicated work in any nonprofit, and you occasionally need HR expertise. So that arrangement, RPV pays $20,000. That's another hefty benefit to the members. We also contract with a lobbying agency to work on behalf of our members, and that saves members about $50,000 a year. We offer an EAP service and trainings, and centralizing that support is $25,000 a year benefit to our members. We also, depending on what's happening in our field any given year, currently the recovery centers are working toward Medicaid reimbursement in 2027 for recovery services, and that's requiring certification, new standards, a lot more infrastructure, a lot of changes. We're working very closely with the state. So for RPV, we saw where there were some gaps in workforce development, data and evaluation. We're now talking about, maybe RPV would play a role in invoicing and reporting once the Medicaid model is adopted. So currently we have $50,000 a year where we're able to support the members through this transition to get them well positioned to succeed once this all happens. Let's see. I can show you real briefly. Let me see. Escape. Here. Here's our member benefit document. Do you see that now? Nope. All right.
No, we don't. We still see your PowerPoint. Sorry.
Okay. Stop share. New share. Okay. Do my entire screen and see what that gets me. Do you see now member benefits?
Yes, now we do. Perfect.
Okay. And this is when we each year are working on the budget because our dues have gone up from year to year. Sometimes they go down. It just depends on the number of grants we have and other things. So this just provides more detail about the advocacy and legislative support, what that looks like. Using our lobbying firm has resulted in literally millions of dollars over the last 3 years. So that one benefit to our members has provided a lot of rewards. Professional development, that's about $40,000 through various grants, and the various trainings that we do and monthly drop-in sessions, our annual conference, which we had a couple weeks ago, and other support services that I think I've mentioned all these. We also do an annual peer audit. We're very connected with a monthly board meeting, a monthly member meeting, and then committee meetings, our legislative committee, our conference committee, a membership committee, and a training committee. So there's a lot of work going on collectively all the time, which creates a lot of really good cohesion. and then your quarterly member retreats and other things. So let me see. And then we have an MOU. Do you now see an MOU in instead of the benefits?
Yep, we sure do.
Thank you. Yeah, this just sets forth our understanding and our expectations of each other. A little bit of history, and then for the member organization itself, it stipulates participation expectations, that you're signing on for a full year, that you identify as a Recovery Partners of Vermont member, and you honor the goals and decisions of the Recovery Partners that we make collectively, even though your first allegiance, if you will, is to your own organization. When you're a member, you sometimes are making compromises for the good of all. Confidentiality, and then we talk about fiscal conduct, expectations around payment, using funds only for their intended purposes. Um, and our, whoops, I got a typo. Also an editor, hate the typos. Um, let's see. Among our membership over the years, we've had state funding, and not all members have used all the funding every year. So that's something that we help them watch for. We can't secure additional funding if we're not using what we're currently given. And then the various ways that we expect compliance. And then recovery partners. We have various things that I'd be glad to share this with you, that our duties to the membership are spelled out, the fiscal and the compliance as well. So that's what those things are. And I'll go back briefly to my.
Susie,
Did I stop?
there's a whole list of questions that are coming in the chat. What I'll
Oh,
do is after
okay.
you finish. No, after you
Yeah, I'm
finish.
almost done.
Okay, we can go through and make sure you answer those. Okay.
Okay. Yep, I wasn't seeing that. So member benefits I just described. Memo of understanding I just went through. Yeah, and just now we're reconvening our membership committee to put some structure around our membership expectations more than what's in the MOU. And also we're exploring ways to expand our membership to further unite Vermont's recovery sector. I mean, there's a lot in recovery in Vermont besides Recovery Partners and the centers and residences, and several that have asked to join. So we're trying to figure out what that looks like. And it's a real opportunity, but we want to do it with some intention and some wisdom. So there you go. I was closer to being done than I realized. Thank you, Sarah, and I'm glad to check the questions or
I'll help facilitate. Just
thanks.
it was great. That was amazing. Thank you so much, Susie. A lot of great information. The first question is from Liz about how many staff are employed at the network. To give just
Thank you. Yeah, the Recovery Partners of Vermont itself has a very small team. There are 4 of us. I'm the first full-time employee, and I joined in January. Prior to that, everyone on RPV's team was part-time, partly to keep costs lower, but our work is getting more complex. So the membership realized the need for a full-time leader. Around the network, the recovery centers have everywhere from, say, a dozen staff up to 25-ish, maybe. So around our 14 members, there are a lot of, I believe we had 73 of them participating in the health benefits last year. We went into the year thinking we might have 40. And so it was much more in demand than we thought, and is growing again this year. So once it's available, it's very well used.
that's awesome. Thanks, Susie.
Mhm.
Liz, are there any follow-up questions that you might have to that?
I guess when you started, was it a kind of peeling off of some administrative capacity from some of the members of the
Oh,
groups? Like I'm just curious how you staffed up to start, and was it, yeah, kind of a component of staff from the other orgs, or
No, it wasn't, but good question. Yeah, we started out, we always had, before we became a membership organization, when we were a network, we always had a network coordinator.
Mhm.
And so we started with the network coordinator who I think started out using, contracting with somebody for the conference event, different things like that.
Mhm.
But in maybe the first year and a half, hired a part-time communication specialist, a part-time fundraiser, and a grant manager who eventually is now my deputy director. So we have a small staff, but they have very specific expertise and
Mhm.
roles, and that helps us to. And we do, or what I heard in your question anyway, is we do carry the burden. We lift some of the drudgery and tasks off of the members so they can focus on their frontline work and we can do some of the behind the scenes
Mhm.
support.
Mhm. Right. Just one other question on grant funding. Did you find that there were kind of core foundations who were interested in supporting the kind of shared capacity of
Mhm.
the broader network? Like, how did you go about finding those funders?
Well, thank you. That we already, as a network, had some
Mhm.
good relationships with donors and people who were interested in our work and various foundations. And so we were able to build on that. And then as we became a membership and realized, this is a whole new game.
Mhm.
We can build this the way is really useful for our members, and that's when
Mhm.
more and more shared services, and especially in our work, the membership has really advocated a lot for better staff compensation and benefits. Most
Mhm.
of the members weren't able to provide much in the way of benefits at all. So over the past few years, we've increased compensation to be more equitable, and it's demanding work in the recovery field of substance use and the complicated
Mhm.
times in our communities. So it was really important for us to provide health benefits to our teams and
Mhm.
EAP because it's
Mhm.
demanding work, and we wanted to retain people rather than, that sounds awful, but use them up. I mean, people would
Mhm.
just get burnt out and then
Mhm.
move along. And we wanted to provide a workspace that was very supportive, and allowed them to really work and grow in the work they had a passion about without
Mhm.
becoming drained by it.
Mhm. Right.
Liz, the one thing I will say, and Andy, I see you sitting there, but I did reach out to the folks at VCF who manage the capacity building grant for VCF, and they will um, look at any applications that are submitted that are looking for funding to catalyze conversations around shared services under that grant.
Awesome.
Yep, I'll just chime in to say, we
Okay.
would, I mean, that's a capacity building grant, and we have had some people apply, and we have funded some projects that are exploring mergers also. And we haven't had requests come through that are exploring shared services, but I think to the extent that that's in capacity building, that would be in the ballpark. And what I would say to anybody on the call is if you're interested to explore that a little further, since we're at the very, very end of that grant cycle. We would probably be talking about a 2026 grant. So we got some time to talk about it. And I would invite you to just reach out and let's have a conversation first so that I can make sure I can steer you in the right direction, and maybe touch base with our committee to see if, if a specific project would have a good shot of being approved.
Thanks, Andy. I did also put in the chat two philanthropy organizations that do fund collaboration, but may or may not do it for Vermont. But we're in conversation with them both about, if they would be so inclined to look at Vermont since they're close by in the Northeast. Just so you have those. Another question is about sharing what you just did, and I think you're willing to do that. Yes, Suzie?
Yep.
Okay,
Yep.
awesome.
That too.
Tammy asked the question, can you clarify a non-member association cannot get group and health insurance in Vermont, but a membership organization can access group healthcare insurance?
Well, I think it's as I understand it, and I'm still learning some of this, but we were already an organization. We were already an umbrella organization with a common mission, vision, purpose, shared goals. We
Mhm.
were already operating, and this just became one of the benefits we could provide our membership. We weren't convening for the sole purpose of becoming associated to get group health coverage.
Yeah, that's my understanding as well, is the difference between an association healthcare plan was one that the entity that was kind of that umbrella, or the entity that was buying the healthcare plans, was there only for healthcare benefit purchase. So
Mhm.
if the organization has broader, multiple different shared services and multiple kind of collaboration points, that's different than an association plan. If there's more deeper questions, let me know, Tammy, and because I am trying to unravel and figure out what it is we would ask for, because I'm not quite clear yet. But if you have deeper questions, please let me know, put them in the chat, or reach out to me, and I'm happy to investigate as I investigate.
Thank you.
Yeah, absolutely. Um, the monthly, so Brandon's asking about the monthly premium average for your group. Suzie.
We just got some numbers about that for the new enrollment, so I can follow up with that, but I can say the Blue Cross Blue Shield, for instance, one employee's was 1337 a month,
Mhm.
um, which I think was fairly typical. So, and I would say that some of our members found out that the family plans got to be really costly, and they hadn't anticipated how different that would be. So that's something to watch for when you're doing things like this.
Thanks, Suzie. And then Sandy asked, how does the RPV board of directors interact with member board of directors? What's the relationship between
Oh,
the board of
good
directors?
question.
Mhm.
We're basically we're here as a technical assistance resource as well. And so, for instance, when we have members going through leadership changes, or they're going through some kind of a different kind of crisis in their community, um, our board, basically, is usually me as the executive director. I can interact with those members and bring it back to the board if we need to do something unusual that we haven't done before, if they're looking for some kind of support that hasn't been needed before, as part of um, in my role being a liaison between the two bodies.
Great. Thanks, Suzie. I don't know if you had any follow-up questions to that. Sandy? No? Good.
Nope.
Okay,
Okay,
awesome.
thanks.
Awesome. And then Amy asked about who the insurance broker is, and I put the link in the chat, but I
Oh,
don't
good.
I'd
Thank you.
talk a little bit about the relationship with them, or how you found them, maybe.
Sure. You know what? My predecessor found them, and they are wonderful. So thank you, Gary DeCarolis. They really meet us where we are. They handle all the complexity of the insurance, and they explain it in a way that is accessible for the various leaders of our member organizations, so that they can make informed decisions for their teams. They're very helpful. They send us monthly newsletters. They're very responsive if we have a situation come up. As I said, we contract with them for HR support. And so sometimes, like this year, we were working on new standards in our move toward Medicaid reimbursement. And part of what they used their HR hours for was to develop an employee handbook to meet some of the new standards. So some of the members used the new handbook as is. Some of them said, we like this new handbook. We want to retain these other policies that we've developed over the years. And so everybody did a little something different with them, but it was a way that we could have one entity working on a project rather than 14 different members all trying to do their own thing. And it was a real time saver, and it helped us have some good consistency. They're just, yeah, great folks to work with. I can't say enough.
That's awesome. Thanks, Suzie.
Mhm.
I see that Chad and Sarah are talking about individual coverage health reimbursement arrangements. I don't know, Chad, if you wanted to kind of talk a little bit about what those are, and or Sarah, how you're exploring that option.
Sarah might be better than me because I'm just diving into it and trying to learn as we speak here. I got a heads up from a staff member yesterday to say, "What about this?" And that's about as far as I've gotten so far.
Okay.
Yeah, and I would be happy to put folks in touch with our finance and operations director, who's the one who introduced us to it. It has reduced our healthcare costs. I think it's been I think it's been challenging for staff, for some staff, and you know, obviously not knowing what's going to happen next year makes it even harder as we're in a open enrollment, but everybody's dealing with that. So, but yeah, I put in the chat the name of the company we use, which is Venture. I will say they're super responsive and helpful, I think, with individual employees. So, but yeah, please feel free. I'll put my email in the chat. If you have specific questions, I'd introduce you to the person who knows more about it than I do.
Great, thank you. All right, are there other, I mean, the intent of this last part of the conversation is just to gather questions. Are there other bigger kind of questions that are out there? You know, as you think through kind of, you know, sharing the how you might share services, questions, you know, around kind of how other organizations might be facing and dealing with the increases in cost for health care. Are there things that people are doing that they'd like to share? Questions that they might have for this amazing group of people who are, you know, working on these similar issues? All right.
Sarah, I can share just we started working with MVP to offer a Section 125 plan,
Mhm.
which has family dependent care, tax pre-tax, you know, you can take money out along with medical FSA. And MVP doesn't require you to have a group plan with them to do that. It costs, I think, $3.50 an employee per month. And it allows you to tap into that so employees can take, I don't know, $5,000 pre-tax to pay for childcare or whatnot. And so it's a great perk to provide to your employees if you can, without having much headache on your end for cost or oversight because they handle it all. So happy to connect folks with that. And I put my name and my email in the chat, but it's been something we've been doing for the last 3 years and it's been great.
Thanks, Chad. That's great. Yeah, if you could put your email in the chat, then folks can grab that if they want to talk more about what that is and how that works. That'd be amazing. Anything else folks want to? Yeah, Sarah, go ahead.
Yeah, I'm curious, and I'm sorry if I missed this, but does anybody have a sense of the ability for, you know, different types of nonprofits to come together to offer health, you know, to collectively purchase health insurance? I can see the amazing benefits, Suzie, that you're offering your members, and that's just tremendous. And I don't know if, you know, when you're working with a diverse set of organizations, whether those kinds of things would work, although I think they could. But yeah, curious about, in particular, since today is about healthcare, any sense of whether you can be a diverse group of nonprofits?
I'm going to leave it silent and I can give what I've learned thus far. Because I think that is the question. That is the question that I, you know, that has been kind of driving the research that I've been doing, is like, what do we do? The small kind of grassroots organizations that really need to come together to kind of support each other and build resilience. Like, what does that look like? So if anybody has any answers, I'm going to leave some silence and then I can. All right. I've not found that model in Vermont. And when I reached out to the Berkshire Nonprofit Center, the reason I did was because that's sort of what they do. They are a nonprofit. They serve only nonprofits of all kinds and shapes. The vast majority of theirs are under $500,000 annual revenue throughout the Berkshires. Under Massachusetts law, they can have what's called that association plan. And so they've been able to they do a variety of different, they're not like TSNE that does traditional shared services, but they do through their membership, they do provide, starting January 1st, a pilot program to provide healthcare benefits to any member that is paying a certain amount. Like they have a premium for the membership. It is a pilot. It is the first time that they've ever done it. There is not another model in Massachusetts that the woman who runs it is aware of. That seems to be the only model that we've seen, unless you're willing to join a PEO, which a lot of nonprofits, for good reasons, are not, willing and interested in joining. So, unfortunately, we have not found that magic, that magic kind of, model yet, but we are always looking and searching. So, I am monitoring the project that they have, and if you want to see, I have the PowerPoint that kind of gives an overview of what the framework of their association plan is. I'm happy to share that with you. Yeah, it is, Amy. It is an association plan. But I can share that. I can share that as kind of a piece of this. When I send out the link to this recording, I will send that information as well, so you can kind of at least look at it and see. And I am in touch with the woman, and I'm happy to share the woman's name. And she's really, really willing and interested in sharing information and having others from Vermont observe how the pilot plays out.
Yeah, and I think, thank you, Sarah. I think, you mentioned advocacy earlier. Is this something that, depending on what you're learning and sharing with all of us, is this something we'd want to come together on and advocate for with our legislators? Yeah. Thanks.
And I would leave it to bigger minds to figure out what it is we're exactly advocating for, because I think if it's illegal under Vermont, for good reason, then we would have to figure out how to get around whatever the legality is. And I'm not a lawyer, so. Other questions or things that folks would like to share with your colleagues?
This is Sandy. I have a question, and this might be covered in the next session on December 5th on shared services, but just like how to start the conversation. Like obviously today is about medical, benefits package and stuff, and I'm interested to hear, the operational back office, finance, IT, HR, office space, potentially, how do anyone here have like suggestions on how to begin the conversations and bringing, a handful of nonprofits, small nonprofits together to explore this? Or will that be covered in December 5th, on December 5th?
We'll open it up for anybody to speak to, but the intent behind the December 5th one is to answer exactly that. So I'm hoping to get Cheryl Gilbert, who has helped start up the I always forget what their acronym is, but it's the councils and agents that come together and formed their own kind of umbrella organization with the intent to share services. So they just are now in the process. I think they're a year and a half, 2 years in. So I'm hoping to be able to help this community kind of learn from that experience. We also have some UVM students that are doing case studies on other shared service models here across the state, and I'm hoping to have a couple of them, if they're willing, to share what they're learning in their case studies, to show kind of the history and how those kind of initial conversations were sparked and catalyzed, and then what was the kind of how are things phased out, right? You're not going to start, you're not going to start right now and then get to where Suzie and her team are in a year, right? Like it's taken time to kind of build that. And so we're looking for models there. There's also the Vermont free clinics. I don't know if Olivia's on there. I think they were exploring at one point to try to figure out how to do that as well. I've asked her to see if she would be willing to share some kind of that initial conversation with this group. And
Sarah,
yes,
could I go ahead and
absolutely, please.
I will mention that it's been a process, so it's a culture shift for our membership. It was, and so it kind of snowballed once we started to see the benefits of. I think we had the advocacy first, and we just started to see that. But now we're exploring, yeah, what kind of, especially as we're moving toward Medicaid, are there ways that we can have more consistency among the financial, even however they're setting up their account codes and things in QuickBooks or whatever they might be using. Are there ways we can have more consistency? And there's been more resistance to that because, it's their numbers, it's their system that their bookkeeper's using or somebody's using, and that feels like it's getting a little too close to the bone somehow. And yet they still see the benefits of what we've achieved in other areas. And so sometimes it just takes a little bit more research and a little bit of hearing from other people's experience and success with something that can just help, advocate for change there, even among your own membership. It sometimes takes a little bit of encouragement and information.
Thank you, Suzie. Sandy, I think you're right. I mean, I think that you are the right question of kind of how do we spark, right? What's needed to start? What's been successful in terms of conversations and kind of culture building and building that trust? And what are the things that people have rallied around at the beginning that are really allowed for the growth in shared services? Other questions, Sandy?
Yeah, on December 5th, we also be talking about like learning like the legal ramifications of, forming sharing services, etc. Will that be discussed?
Yeah, we will. I hadn't thought of that, and I will pull some folks in and see if I can get some folks to add to the conversation. Thank you, Sandy, that's a good question. Anything else?
Sandy, I was just going to say that we're Vital Communities is based in the Upper Valley, so we're on both sides of the river. But in this region, we've started some conversations with, there's a group of executive directors that meets quarterly, and we're starting to think about shared services. It hasn't gotten super far, but we're hoping to launch something with some DEI shared services later this year and then into next year. So very nascent, but yeah, we're trying to explore that with one sliver of those kind of back office services.
Thanks.
And
Sarah.
my email's in the chat if you want to reach out about it. Yeah.
Awesome. All right. Any other questions or amazing practices? The last thing I'm going to put in the chat before I give you back some time in your day is this is a webinar that was done recently, I think in the last month, on different ways that nonprofits are trying to share or reduce costs for healthcare. It is really dry, and it's an hour and a half. So, but it does have some good ideas. One of which I think Chad mentioned, and there's other just ideas in this. So that might be something in the meantime just to take a look at. It is very dry. That is the only thing I will say about it as a resource, but we will be sharing the resources that we talked about. Suzie thank you so much for joining us today and for sharing everything. That was incredibly helpful, and I'm hoping that people got some great ideas, made some connections that you can use in your work. And we'll send out the recording, some of the materials that we have. We'll send out some of the links that we put in the chat. Really appreciate everybody coming out. Look forward to seeing you guys in December. Sandy, if like Sandy, there's other questions that you would like to have specifically answered or people we'd like to have available during the next one, please just reach out to me and let me know. And I will be happy to see if I can get some linkages to folks and get folks here to answer some of your questions and to make some connections. I put my email in the chat just in case anybody doesn't have it. And I just want to say thank you, and have a good weekend of this first winter lake weekend. And thank you to our co-sponsors. I really appreciate you guys stepping up and helping out with us. And thank you, Suzie, again for spending some time with us today.
Thank you.
Awesome. Thanks, everybody.
Bye-bye.
Thank you, Lauren.